We're going to transition into something that has some relation to erosion, in that for the devastated outlet, some of the conditions that cause erosion are also play a part in the patient that develops a devastated outlet. Let's see. Okay. Those are my disclosures. So we're going to look at what is the devastated outlet, and is there a possibility that we can prevent the development of some of the complications that we see in these patients that develop a devastated outlet. We'll look at some of the algorithms and talk briefly about patient preparation. So devastation, it's great destruction or damage and causes someone, including me, when I'm dealing with these patients, and many of you, a lot of shock and grief. What are the factors? Radiation, can be cryo, HIFU, and the multiple treatments that we perform to address the strictured outlet, and that can be either with cold manipulations or with energy or with injectable agents such as mitomycin. We know well about the radiation effects on the lower urinary tract, and this has been studied and evaluated. We know about the fibrosis that develops over time and the ischemia that develops in the obliterative endarteritis. This is just a look at the overall bladder toxicity that we see in different types of pelvic tumors. And the interesting thing I find about the RTOG and ERTC scoring is that while they have scoring for complications related to the bladder, they really don't say anything about the urethra. There's nothing specific to that. But we are very familiar with this presentation, or this appearance that is clearly radiation urethritis. And what are the things that we want to prevent in these people? We want to prevent the development of fistula that will take you closer to the progression of the need for urinary diversion. We've talked some about radiation already, and the relationship to recto-urethral fistula is fairly well established. It's very much associated with radiation exposure and with manipulations to the bladder neck or the urethra. But it can occur at any time, but you really can't predict it only based on the type of radiation. These are two radiation oncology treatment planning schema, and one patient who had severe complications and the other who had none, and the overall planning seems very similar. But we can see for sure that you have a significant dose both at the bladder neck and in the bulbar urethra. What about other treatments or non-prostatectomy treatments to the pelvis for prostate cancer? For example, with HIFU, primary HIFU alone has a fairly low incidence of recto-urethral fistula, but a lot of other urinary complications in combination. When you look at salvage local therapy, we see a lot of urinary complications that are related to secondary therapy with brachy, cryo, or HIFU, and around 3% for all of those in terms of recto-urethral fistula. But again, incontinence and urethral stricture are not insignificant. Looking at the surgical approach or the treatment of recto-urethral fistula, we can see in comparing when patients have only had surgical treatment for prostate cancer versus radiation, that you more so get involved with treatments that involve, for example, cystectomy and ileal conduit, and in this case, robotic salvage prostatectomy. This is just a case of one of my partners, Dr. Smith, in a patient that had a recto-urethral fistula post-radiation, of course. And you're just looking at the fistula going through or exiting through the rectum, setting up of the perineal Bookwalter retractor. And here we can see the 5 French open-ended catheter going from the urethra into the rectum, repair of the urethra, and then interposition of the gracilis flap. This is another look at algorithm by Drew Peterson, looking at the overall management and in terms of the therapy for treating these recto-urethral fistulas. But in general, what we really want in the end is to how do we avoid getting to this point? Let's look at another devastating complication, pubic-prostatic or urosymphyseal fistula. And these are, again, almost exclusively in patients who have been radiated and had endoscopic management of bladder neck contracture. And it's often heralded, again, by any patient that has suprapubic pain. At that point, I almost start looking for it, even if you don't see any absolute sign of it on examination, on cystoscopic examination or on imaging. And this is a patient who, in combination on cystoscopy, you can see this fat. They also have a recto-urethral fistula, and when you do a retrograde urethrogram, you see contrast into the rectum. But again, suprapubic pain tells us a lot, and we can almost always see on appropriate MRI imaging that increased intensity along the symphysis. Other signs that we can see after we've had deterioration of the outlet as it continues to degrade is extravasation of the urine along the adductor compartment. Sometimes there will be erythema. There can also be a bullous edema and a rash. This happened to me, or I witnessed this in a patient who also had an artificial urinary sphincter, and when the sphincter was activated or on, then he would have leakage of the urine through an extravasation through the degraded bladder neck, and it went down the adductor compartment. So it's important to try to recognize that early, someone who has pain with the artificial urinary sphincter, and the pain goes away when the artificial urinary sphincter is deactivated. And this is just showing that the fluid that is going down both adductor compartments. Of course, the next thing is to do a suprapubic catheter first, and then maybe a temporary diversion, and then followed by urinary diversion. This is another paper looking at urosymphyseal fistula and the potential for utilizing intermediate therapies, hyperbaric oxygen, but often we end up with the surgical route. In the majority of the cases that I get at MD Anderson, we end up with a multi-team approach: urology, colorectal, orthopedic, and plastic teams. This particular patient had an Indiana pouch. This later, he had an IPP as well subsequently. There's always a debate about how much resection of the symphysis to do. In some cases, it's not necessary to resect it, but you have to be prepared that the patient may have problems later and have to go back to the operating room if it hasn't been appropriately debrided or resected. When we're looking at this exenerative surgery, it's fairly high morbidity, even in comparison to regular cystectomy and diversion, which have a fairly high complication rate and a 30-day complication and readmission rate. And some of the factors that lead to this morbidity are listed here. So the question is, where could we intervene earlier to prevent this progression to this devastated outlet? I would propose that it comes even earlier, even in the selection of actual therapy. Are we doing the best job of selecting an optimal therapy where we don't have to do secondary procedures that then result in more of an insult to the tissues? If we do end up with a stricture, do we need to consider intervening before we've done too many dilations or VIUs? What will be the effect of Optilume in this situation? Do we need to reconstruct the bladder neck much earlier? And we don't know yet what will be the outcome now that we're going to these focal and whole gland ablative therapies for prostate cancer. Will that be better in terms of the bulbar urethra? So management of the devastated outlet should, evolve into how do we intervene to prevent this devascularization, progressive ischemia? Can we identify patients who are going to have complications from radiation and shouldn't be radiated? And we're in talks with our radiation oncologists to start looking at that, because they, although we blame them, they're also interested in identifying patients that are going to have complications so that they can avoid those as well. You know, what is the, is there a genotype? Are there markers that we can utilize to identify these patients? And then we have to prepare patients when we see what the outlet looks like and we know what the natural progression is, to prepare them for what the long-term outlook may be, and they may opt for being diverted a little bit earlier. And that's the end for that one.